On to the second talk. It's by Dr. Hariharan Regunath, and the topic is antimicrobial resistance, clinical primer, diagnostics, and newer drugs. So, Dr. Hariharan Regunath, he is a critical care physician and infectious disease consultant at University of Maryland, Baltimore, Washington Medical Center. He is also an adjunct associate professor at University of Maryland, Baltimore, and University of Missouri, Columbia. He also has a teleconsultation practice and is the owner of Infectious Disease Alliance of Maryland. He had a early education and training for MBBS from Madurai Medical College, Madurai, MD in internal medicine from Kasturba Hospital and Kasturba Medical College, Manipal, American Board Internal Medicine, Infectious Disease and Critical Care Training from University of Missouri, Columbia. His interests are antibacterial resistance, community-acquired pneumonia, nosocomial infections, infective endocarditis, quality improvement, sepsis, ARDS, mechanical ventilation, and medical education. I'm very pleased to invite Dr. Hariharan Regunath for the next presentation. Over to you, Hari.
Thank you, madam. Can you hear me?
Yes, very well.
Awesome. Yeah, it's always very enlightening to listen to lectures from Manipal, and being a speaker is an honor. Thank you so much. And first things first, Sagar, nice to meet you after a long time. It was a very good talk. I enjoyed it. I enjoyed every bit of it. Congratulations. And let's move on. I realized the talk is only for 45 minutes, so I'm going to be quick and fast. Let me share my screen right here. Okay, are you able to see my screen, Ben?
We are able to see.
Okay.
Yes, perfect.
Continue to share. Awesome. All right. So I do not have any disclosures. There are about 45 slides to be on the dot. Some of the slides I'll go over faster. Some of the slides I'll spend a little more time. The idea for giving this talk was great. And in regards to the World Antimicrobial Awareness Week, what can we do as clinical practitioners to think in regards to infections, particularly drug-resistant infections? I'm not going to regurgitate what's available in the guidelines. The guidelines are available for everybody. You can go back and refer and read. I'm going to give you my 2 cents on what I see in clinical practice and how do I handle them, and what are the concepts and principles of practice that I exercise when it comes to approaching infections in clinical practice. So that's really what I'm going to talk about. I probably won't be talking about the bread and butter treatment of MSSA versus MRSA versus multi-drug resistant infections, but rather what principles, how do I recognize, how do I treat them, how do I approach how do I approach the choice on antibiotics in regards to what resistance patterns I'm seeing in the context of the patient's clinical presentation. As we know, antimicrobial resistance is not a new concept. It's been there for ages. It's been there since life has been in this planet. It's a natural phenomenon that predates modern selective pressure of clinical antibiotic use. The very use of antibiotics is really what fosters the emergence of resistance, and it selects out bacteria that develop resistance. The more antibiotics we use, the more complex the resistance patterns we're seeing over the decades. And it's not just in humans. We use antibiotics in agriculture. We use antibiotics in farming, in animals. So what circulates in the animals, the human-animal interface, the human-environment interface, is where bacteria circulate. And that's how we maintain the pool of resistant antibiotics. Even if we curb the use on human infections, there's a lot more work that needs to be done in curbing the antimicrobial use in agriculture as well. So it's not an isolated problem, it's a universal problem. Some basics, this in regards to how antimicrobial resistance is acquired. There is innate resistance. There are some mechanisms that are innately present in bacteria. They are natural, like for gram-negative, you cannot use gram-positive drugs. For gram-positive drugs, such as vancomycin, is not really effective on gram-negative. So those are innate resistance mechanisms based on the structure of the cell wall, the structure of the cell membrane. But there are other mechanisms by which you can transfer resistance from one bacteria to the other. Transformation is basically an uptake of genetic material from one bacteria to another. A transduction is through a virus. Conjugation, you can think of it as bacteria love each other and they love to transfer genetic elements from one to another when they love each other. And conjugation is basically a transposition of the DNA sequences from one to another without love. Now, apart from the traditional mechanisms, there are other clinically significant but not very well recognized mechanisms which are present only in the human body or in biologic systems, but not present or demonstrated in the laboratory. So two of them are emerging concepts which have been well recognized now, but we are struggling to identify how to test for them, is antibiotic tolerance. To keep it simple, tolerance is a mechanism where the bacteria, they remain susceptible, but they can in vivo slow down the processes responsible for drug killing. And that way, it takes a much longer time for an antibiotic to exert its killing effect. As you can see on the graph on the right side, where the blue line, the time to kill, the time for the same MIC. MIC is on the y-axis and the time to kill is on the x-axis. It takes much longer. The green line would be a projection of what you would expect based on the susceptibility results, but really in vivo, it takes a much longer time. Now, what does this tell us? These are mechanisms that we have to keep in mind when we are treating deep-seated infections and sometimes go longer in regards to treatment when you're particularly dealing with a deep-seated infection such as osteomyelitis or endocarditis. You know, the guidelines say 6 weeks, but sometimes we go 8 weeks, 12 weeks, or depending on if it's a high inoculum infection or a serious infection or a difficult to treat pathogens. A little different concept is called antibiotic persistence, where there is a presence of a heterogeneous subpopulation of persisting bacteria within the usually determined duration of treatment, meaning within the same treatment duration, you have a group of bacteria in that same subpopulation that are different. They develop a mechanism similar to tolerance, but not at the commencement of treatment, but through it as you start treating. It selects out that. So that's what antibiotic persistence means. Now, it's a little different than what's called persistent infection. Persistent infection is due to inadequate control or development of resistance, which is different. Resistance means the in vitro test will show that it is not susceptible to that drug. So these two concepts are in vivo mechanisms without any demonstrable lab evidence of resistance. So something to be kept in mind. Now let's jump into gram-positives. Gram-positives, this is one slide that talks about what mechanisms exist. For beta-lactams, the genes involved are the BLA-Z gene, which is primarily targeted towards, it's a beta-lactamase that hydrolyzes penicillins. Then for the most common mechanism in Staph aureus is actually through MEK-A. MEK-A, particularly what it brings in is an alterations in penicillin binding protein 2A that has low affinity to beta-lactams, particularly methicillin or oxacillin. Now you can see that within brackets, it has no effect on ceftaroline or ceftibiprole. Ceftibiprole is mostly used in the laboratory settings as a marker for methicillin resistance, and ceftaroline is a newer antibiotic that's available. Similarly, for vancomycin resistance, VAN-A is the gene, which is acquired from enterococci. The use of vancomycin for C. diff infections is believed to foster the development or select out the emergence of vancomycin-resistant enterococci, and the enterococci give it to Staph aureus, and that's how we see vancomycin-resistant Staph aureus. It's in clinical practice in the US, it's quite rare to see vancomycin-resistant Staph aureus, but that may not be the case elsewhere across the globe. Now, the resistance to other antibiotics such as linezolid and ceftaroline are related to the modification. the modification of the targets on which they work, namely linezolid for the ribosomes and ceftaroline for PBP2A. And for other antibiotics such as daptomycin, which is a cell membrane active agent, it's the modification in the targets on the cell membrane. Now, what we have to remember for gram-positives is that their beta-lactamases, which is the most common mechanism, they secrete it or excrete it into their environment. They coat themselves around. As they coat themselves around, the more bacteria in a given inoculum, the more beta-lactamases around in their environment, and hence the MIC is a cumulative effect of that inoculum, how big the inoculum is. So that's where we talk about the pitfalls of the MICs. The MICs are generally estimated over a short period in the lab based on optical density data in cultures, how much turbidity it changes, how dense is the growth. So normally, then you call it a low inoculum if you test it with inoculation of 5 cross 10 power 5 cells with bacteria growing exponentially at temperatures, etc. And the MICs are really a reflection of the pharmacokinetics and pharmacodynamics, which are functions of which should be anticipated densities of infecting population, but that's really not the case. The MICs are based on the densities that we are using in the lab. What is the density? What is the inoculum? How much bacteria is there in a body in a given different site? We don't really think about it hard enough in clinical practice. So really, that's where it's important for us to think about if it's endocarditis, osteomyelitis, severe pneumonia. If somebody's culture has turned positive pretty quickly, as soon as the sample is submitted within 24 hours, and very severe or critically ill patients, that's where you think about the inoculum effect. And you think with a higher inoculum, there's also a higher chance of things like antibiotic tolerance, antibiotic persistence. Now, unfortunately, there is no in vitro test for how much we can estimate in regards to inoculum effect, but the CLSI is in the developing phase. They are trying to come up with using a high inoculum by having the number of cells higher, 5 times 10 power 7 cells per ml, and using an MIC breakpoint of more than 16 micrograms per ml, for example, in regards to MRSA. So they are thinking about it. I have it in the reference link in the slide as a YouTube link that talks about the inoculum effect. These slides can be shared with the audience, and they can go ahead and look at it. Now, Staph aureus, including MRSA, what's old and what's new? Now, we know that Staph aureus infections, MRSA infections, MSSA infections, even bacteremias, they take sometimes up to 7 days or longer to clear. And it's very common to have clinical failure and relapses even with the appropriate therapy. And even with so much advancements in diagnostics and treatment, our mortality hasn't really changed in decades. Now, what updates do we have and what limitations have we realized? In the microbiological assays, we recognize that bicarbonate, which is an intracellular buffer which is available in vivo, it is actually a hidden modulator of susceptibility. In the presence of bicarbonate, bacteria and antibiotics behave different. And that's really where the combination regimens for MRSA and MSSA, even with the appropriate MIC values, there is a value. Vancomycin and beta-lactam, daptomycin with beta-lactam, and daptomycin with ceftaroline. These are the combinations that are most widely reported in literature, in recent literature within the past 10 years, particularly stemming off from an effect called seesaw effect. The seesaw effect, to keep it simple, means that if you use 2 active agents, one beta-lactam and one non-beta-lactam, such as vancomycin or daptomycin for MRSA, the bacteria, it saturates the penicillin binding proteins, and bacteria can only focus on developing resistance to one mechanism. So if you use another drug with a different mechanism, they kind of get confused. So this is as simple as I can explain, the seesaw effect, but there is a role for dual antibiotic therapy early during the infection in high inoculum infections. So there are sub-MIC effects of beta-lactams on Staph aureus, which also has something to do with your immunity. There is decreased cell wall cross-linking that causes greater susceptibility to antimicrobial peptides, and it improves your macrophage release of interleukin-1. It reduces the host cell adherence to invasion, and there are some reduced beta-lactam MIC when bicarbonate is used as a physiological buffer. So there are some sub-MIC effects of beta-lactams on Staph aureus, which makes a case for adding a beta-lactam to vancomycin or daptomycin. Now, here is a conceptual pathway risk stratification in antibiotic therapy for MRSA bacteremia, where if you see an initial positive culture, particularly in high inoculum infections, then you try and start with a combination therapy, daptomycin and ceftaroline, and daptomycin plus or an anti-staphylococcal beta-lactam. Anything you could choose. You can choose cefazolin too. Now, vancomycin plus another beta-lactam is also acceptable. Now, why do we do that? To enhance the rates of clearance of bacteremia. In other words, to achieve a quick microbiologic cure. And then reevaluate your blood cultures in about 72 to 96 hours and then determine when and how to de-escalate depending on the MIC values that you're seeing. Now, it's very important for you to follow through every single bacterial culture in that patient and do susceptibilities on every single positive culture results. It doesn't matter. Labs may say we did on the same day. They may say you sent me 2 sets. We did susceptibility on one. We assumed the susceptibility for the other. At least do one susceptibility results completely for every single day, because Staph aureus is believed to be in a continuous heterogeneous state. And as resistance develops, as the inoculum is high, we may see the MIC creep up for cefazolin as well as MRSA with the respective drugs, cefazolin or vancomycin MIC. So you have to really watch the MICs for every single culture until it's completely clear. Now, enterococci, they used to be group T strep. They have intrinsic resistance to cephalosporins. They are intrinsically resistant to tobracanamycin. Bactrim will not work because they take up folate from the environment, so it really bypasses the mechanism with which Bactrim works. Now, with enterococci, the updates are there's persistent bloodstream infection is associated with a higher mortality and a higher relapse rate, even after successful treatment. And these relapses can sometimes happen even after 3 months. You would have treated an endocarditis, it would have you completed treatment for 6 weeks, and then 6 months later, they have a recurrence, native valve endocarditis, even without prosthetic valves. Now, Ephesium is often ampicillin and vancomycin resistant. The fecalis, E. fecalis, is usually susceptible to ampicillin more than 90% of the time. So linezolid is the only FDA-approved drug for VRE bacteremia, and that's recommended in the endocarditis guidelines. We can use other antibiotics based on the susceptibility results. If it's fecalis, we could use penicillin, ampicillin, or piperacillin. If it is ampicillin resistant, we could use vancomycin and daptomycin. Now, remember that daptomycin dosing for enterococcus is higher. It's 8 to 10 or 10 milligram per kilogram of adjusted body weight or higher. And you could use tigecycline, but tigecycline does not have intravascular, or in other words, the blood concentrations are not good. So it's only used for as a second line or third line agent for tissue infections. And obviously these are the options available for vancomycin resistant enterococci, which are primarily daptomycin, tigecycline, and quinaprestin, dalfaprestin. Now, ceftriaxone and cefotaxime see that they are inherently resistant to cephalosporins, but the ceftriaxone and cefotaxime are used in combination with ampicillin for endocarditis for the same reasons I mentioned before, that a combination double beta-lactam therapy may have advantages in saturating the penicillin-binding proteins and enhancing the efficacy of a susceptible antibiotic. There are scores that are available which can help you in determining if a patient needs an echocardiogram in cases of bacteremia. Those scores are the NOVA scores and DNOVA scores. Essentially, they talk about the clinical variables that will make you think about endocarditis. such as duration of symptoms more than 7 days, is there a heart murmur, how long have the patient been sick, etc. And in regards to enterococci, we don't have as much robust data in regards to combination therapy, other than that is that we use for infective endocarditis. Now, this is one slide that talks about the different genes involved in antibiotic resistance. And particularly the most important ones are the VAN genes, the VAN A, VAN B, and VAN C clusters that are present, which are often available in the BioFire that will help you determine if you have to use, if you can use vancomycin or if you have to use daptomycin, if any of the VAN genes are present. Linezolid resistance is not very common, but with the widespread use with endocarditis, it is mounting. In those cases, daptomycin resistance as well, particularly that related to the LIA FSR gene loci. And the problem with daptomycin is highly protein bound, and the levels in the tissues and in the blood can swing very badly to the point that there is a low threshold for development of resistance with daptomycin monotherapy. So that in itself is mounting up as more and more of a concern, making a case for combination therapy, but we don't have any clinical data yet. For streptococci, it's simpler. The penicillin resistance is related to alterations in the penicillin binding protein. The linezolid resistance and daptomycin resistance. Daptomycin resistance is literally unheard of, but we don't use daptomycin much for streptococcal infections. We often use it for MRSA or enterococci. Now, this is a novel drug class called DNA polymerase III inhibitors. As you can see, the makers are Accurex technology, and they they are claiming that these have activity against a lot of gram-positives that are ignored as a focus of drug development. Unfortunately, just like how life is, the approach to infectious diseases is also the negatives get more attention than the positives. Here, these are guanine analogs that inhibit DNA replication. They are very selective, and they do not have any effect on gram-negative rods. So they are also bactericidal for C. difficile. So they are really looked upon as a new breakthrough in this century, as a major breakthrough for treating drug-resistant gram-positives. And the makers claim that they have more than 600 novel compounds targeting potentially all problematic gram-positives. And these enzymes, the DNA polymerase 3C enzyme, particularly only occur in gram-positives, and they're not even present in eukaryotes. So that really speaks to the specificity of this drug. Now, gram-negatives, this is really a large topic. It can be a topic by itself, but I'm going to skim through the resistance mechanisms quickly. The gram-negatives are very fancy. They have a periplasmic space. There's an outer membrane that traps a periplasmic space outside their cell wall and cell membrane. And that really is where your beta-lactamases are conserved. So whatever little beta-lactamase, the gram-positives have to make a lot of beta-lactamases to coat themselves around. But the gram-negatives can make very little beta-lactamase, and they can still be effective circulating within the periplasmic space. So that really talks to their efficiency. That's why there is a lot of beta-lactamase classes that we talk about in gram-negatives. So these are the successive generations, meaning the lowest level of expression or the lowest degree of resistance is AMP-C beta-lactamases, where you will see the first generation cephalosporin to be resistant when the gene is expressed in smaller quantities. As it becomes a high-level AMP-C, you will see more resistance to all cephalosporins. Then when they go into the third generation cephalosporins, it can be a different mechanism called extended spectrum beta-lactamases, where you will see resistance to ceftriaxone, cefotaxime, and ceftazidime. And the next level of higher resistance is carbapenemases, which is resistance to carbapenems. And it can be due to enzymatic degradation or due to other mechanisms, such as reducing the porin or efflux pumps. And there are different types of carbapenemases. There are serine carbapenemases, metallocarbapenemases, etc. But from lower level to higher level, it goes from AMP-C to ESBL to carbapenemase. Now, we can classify them based on molecular class or based on clinical class. The clinical class makes more sense, such as AMP-C, ESBL, and carbapenemase. The molecular classes are class A, class B, class C, and class D. Now, the easier way, I always hated the nomenclature in microbiology because it's so complex and it depends on who creates it. The easy way to remember is class C and AMP-C sound together. So I always say class C means AMP-C. And then class B is MBL, beta lactamases, which are metallo-beta lactamases. So always remember B and C. And then class A is always the topper of the class, means this is the topper among the most common resistance mechanisms and a problematic resistance mechanism, which I remember that as ESBL and KPC. Because ESBL has become a community-acquired pathogen now, and KPCs are the most common carbapenemases in the United States. So that's how I remember these classifications. Now, AMP-C, how am I supposed to remember? AMP-C, C stands for cephalosporin. So it knocks off all the cephalosporins. There are some mnemonics that you could use. The most recent one that is more accurate in talking about which bacteria produce this type of cephalosporin consistently is heck yes, the second one that's mentioned here. Enterobacter cloacae, Citrobacter fruindia, and Klebsiella aerogenes. Those three are the pathogens, the ECK of the heck. They consistently produce a cephalosporinase. Now, that's why it's very, very important for you to remember these, is because without the knowledge of the bacteria that produce these resistances, it'll be harder for you to exercise principles of antimicrobial resistance. There is no test to detect this. We go with the susceptibility results and the knowledge of this bacteria. ESBL is an extension of the AMP-C, but it's a different gene loci. The phenotypic pattern is it shows resistance to third-generation cephalosporins such as ceftriaxone and cefotaxime. Now, they are sensitive to cefotetan and cefoxitin, but they are resistant to third-generation cephalosporins. So you could still use the cefamycins for treatment. Now, there are different types of ESBLs. The most common one is the CTX-M that is identified in your BioFire. There are others. There are TEM, there are SHV, and there are OX-A, and there is a subtle difference in their phenotypic performances, as you can see. The importance of recognizing these is for you to effectively use antibiotics, targeted antimicrobial therapy based on the BioFire results. So that's why these are important. Now, understand that these are all the ESBL gene loci are most of the time located in the plasmid. The AMP-C gene focus can be in the DNA, main DNA of the bacteria, or it can be in the plasmid. But the ECK that I spoke about, they have it in their main DNA. That's why they consistently express AMP-C, as opposed to ESBL, which is transmissible from one bacteria to another. Carbapenem resistance. Carbapenem resistance is due to a carbapenemase enzyme or a non-carbapenemase. The non-carbapenemase is more common, about 40 to 60% of US cases. Carbapenemase producing are less than the non-carbapenemase mechanisms, but it's important to know if they're carbapenemase producing or not, because some of the newer agents are very specific to which carbapenemase they work on. So as you can see, there are serine carbapenemases. The most important one is KPC, and the metallocarbapenemase, the most important one is NDM, which is the New Delhi metallo-beta lactamase. Now, we just spoke about this. Now, the carbapenem testing there are a lot of tests that are available depending on what your lab can do. The FDA and the CDC provide guidance on the test performance, the labor cost, depending on what you can use. So there's really a lot of tests that are available. But the BioFire spits out the genes that are responsible for carbapenemases, most of the problematic ones, including the NDM, KPC, IMP, etc. Now, this is one slide that just by looking at the susceptibility results, what can you infer based on the resistance pattern? Here you can see on the left side, you see AMP-C, ESBL, KPC, NDM, and the shades of pink get darker as you go down, meaning as you go down, they're getting more and more resistance, right? From first generation in the rows, you can see In the columns, you can see first generation, second generation cephalosporin. Cefoxitin is separate because cefoxitin used in the lab for a variety of reasons to identify different types of resistance. And third generation, fourth generation cephalosporin, then carbapenem, then aztreonam. So it goes from left to right, from the lowest generation cephalosporin to a more broader beta-lactam with increasing activity. So low-level AMP-C, as you can see, it has when the gene is expressed at a very low level, you will see susceptibility to cefazolin, which is the first generation cephalosporin. Let's say you have an Enterobacter cloacae, and the first culture result from your urine sample comes up as susceptible to cefazolin and ceftriaxone, etc., etc., etc. And you start treating it without knowing that Enterobacter cloacae has a constitutive AMP-C. If you did not kill all the bacteria in the urine and they had a complicated UTI, let's say they have a renal abscess or there's an obstruction, the gene gets activated and it will become resistant through your treatment, causing treatment failure. Sometimes you see resistance to cefazolin, but susceptible to ceftriaxone. When you see that, then that should ring a bell saying, nope, that might be an AMP-C, so I may want to avoid a cephalosporin. Now, if it is not an Enterobacter cloacae, if it is something else like an E. coli, is it possible it can be a plasmid-mediated AMP-C? Yes, it's possible, but it really depends on whether it's a complicated UTI or a simple cystitis or what are you dealing with, for example. A high-level AMP-C, when it is fully expressed, you can see it is resistant. It's red from first generation, second generation to the third generation cephalosporin. But for all AMP-Cs, you can see that the cefepime is a drug of choice, where it is green, which is the fourth generation cephalosporin. The carbapenems will work. When it comes to ESBL, only carbapenems work. Nothing else works. You could use a beta-lactamase inhibitor in the lab to know if it's an ESBL or not. For KPC, we really don't have most of the drugs that can be tested in the lab are not active. For NDM, the same, except for aztreonam. It will be susceptible to aztreonam. So here is an example of how your susceptibility patterns would look like. Just like how this is for Enterobacter cloacae, you can see for AMP-C, your cefoxitin is resistant, your ceftriaxone is resistant. So in this example, it is a high-level AMP-C. If your cefoxitin is susceptible and your ceftriaxone is resistant, then you would think about a low-level AMP-C, or it could be, so cefoxitin susceptible and ceftriaxone susceptible. It's possible that it could be a low-level AMP-C. If your cefoxitin is susceptible and your ceftriaxone is resistant, and it's also resistant to your, we don't have cefotaxime here. So second and the third generation cephalosporins, if it's resistant, you think about ESBL. Now, when it comes to the fourth generation cephalosporin, which is cefepime, when you look at it, if it is somewhere susceptible or susceptible dose dependent and resistant, then you have to think about an ESBL as well. Now, as you move on to KPC and NDM, you can see that they are resistant to most cephalosporins, but the KPC remains susceptible to ceftazidime avibactam, which is a newer non-beta-lactam beta-lactamase inhibitor. When it comes to NDM, it's only susceptible to aztreonam. So just by looking at the susceptibility result, you might be able to ascertain what type of resistance pattern am I encountering in a given gram-negative pathogen. There are bacteria which have intrinsic carbapenem resistance, which Stenotrophomonas has a carbometallo-beta-lactamase by itself. So most of the time, we see steno growing in respiratory cultures in ICUs that use meropenem a lot because it selects out the Stenotrophomonas to grow. Imipenem resistance is inherent in Proteus, Providentia, and Morganella. And it's important for you to test the carbapenems independently. You cannot assume if they are meropenem resistant, it'll be resistant to ertapenem and imipenem. You have to test it out individually. Now, drug-resistant Pseudomonas, MDR is resistant to at least 3 out of the 5 classes listed below, as opposed to difficult to treat Pseudomonas is where it's not susceptible to all of the following: piptazo, ceftazidime, all beta-lactams, aztreonam, meropenem, imipenem, as well as fluoroquinolones. So the distinction between MDR and DTR is important because the choices might be a little different. You would be lucky if you are still susceptible to fluoroquinolone and aminoglycosides, but for a large part, they've fallen out of favor in the pharmacy world because of adverse effects related to prolonged use of these antibiotics in relation to their toxicity profiles. So jumping after understanding what resistance patterns we are seeing, it's important to choose what antibiotic we are going to use, right? But before that, before we know all these culture results, we still start antibiotics empirically. And how do we do that? We have to define the syndromic diagnosis. Is it pneumonia? Is it UTI? Is it a bloodstream infection? Is it sepsis, septic shock? How do you get that? History and physical exam. And very, very important. 99% of the time when we don't know something, we miss something in history and physical is what they say. You really need to know what pathogens are associated with that particular organ system infection in your epidemiology. Look at your local antibiogram. Look at how the resistance patterns are among the population of patients you're seeing in your hospital. A good antibiogram is usually, depending on the volume of every hospital, at least a year, they should update it. Every quarterly would be ideal. But you need, for every bacteria, you need at least a sample of, at least 30 isolates are needed to make some meaningful judgments in a tabular form in regards to making sense of the percentages you're seeing for one particular bacteria and one particular drug. So every box should have, the counts of the colony should be more than, or every bacterial isolate, the number of isolates should be more than 30 to make meaningful interpretations. Now, your empiric therapy should be based on 1, 2, and 3, and then preferably you collect the culture samples prior to the first dose without any delays in patients with delays to first dose of antibiotic in patients who are critically ill. And then based on your culture results, you de-escalate. Now, it can be based on genotypic results or phenotypic results depending on the sample. Blood culture results, there's a lot more advancements now with the PCR, the biofires that we're able to de-escalate quickly. Sputum samples, not many of us have the ability to do a direct PCR test to the sputum sample with its limitations, etc. So you have to wait for the culture results. Tissue samples, we still have to wait for the culture results, which could take longer. Now, how to determine risk before starting empiric therapy? Please look at prior antimicrobial use. If they had used any IV antibiotics within the past 90 days, within 30 days is a lot more sensitive and specific. Within 60 days, more so than 90 days, but less than 90 days is a good cutoff, particularly for MRSA and drug-resistant Pseudomonas. If you really don't have a history of MRSA or drug-resistant Pseudomonas that didn't receive an IV antibiotics less than 90 days, you could use a beta-lactam or a fluoroquinolone, etc. It could be narrow in regards to your empiric therapy. The setting, if it is community or nosocomial onset, what sort of contacts do they have? Are they a healthcare worker? Do they work in a hospital? Did they travel anywhere in regards to, these are important in US because there are a lot of travelers that travel abroad and come back, and depending on where they traveled, then the prevalence of drug-resistant infections is extrapolated accordingly. Now, what is important for populations in the US is MRSA and ESBL are no more hospital-acquired pathogens. They are in the community. So we have a low threshold to start vancomycin or a carbapenem, depending on how severe they present. History of prior colonization or infection is important, particularly most relevant when such an infection occurred within the past 6 months. If certain comorbidities, you can have certain risk factors. History of stroke, risk for MDR, Pseudomonas, cirrhosis, diabetics, heart disease, neurogenic bladder, think about fluoroquinolone resistant E. coli. What these associations mean, I don't know, but this is what is available in the literature. When you look at the antibiogram, if an antibiotic for a drug is less than 80% susceptible, that means it's more than 20% resistant in your institutional antibiogram, that particular choice of antibiotics may not be an effective empiric antibiotic. Now, treatment choices for AMP-C for Enterobacterales, which is E. coli, Klebsiella proteus. If you think about particularly the Enterobacter cloacae, Klebsiella aerogenes, in those pathogens, if they are very sick, you want to use a carbapenem. If they are not sick, you can use cefepime now too, because the cefepime has come up on the recommendations in the 2023 guidelines as opposed to 2019 guidelines. But in all cases, even if it is susceptible to ceftriaxone or ceftazidime, you avoid them. And Zosyn is a potent inducer of the enzyme, so you avoid Zosyn as well. For uncomplicated infections, if they are susceptible to other drugs, the older drugs, fluoroquinolones and Bactrim, you could use it like uncomplicated UTI. Now, the table talks about it's a gene that is induced, and which antibiotics are potent inducers and which antibiotics are not potent inducers. Now, the carbapenems, they induce the gene, but they are not digested by the gene, by the product, which is the cephalosporinase. So the carbapenems can still be used in serious infections. It's very effective. The same way for cefepime. Cefepime is not hydrolyzed by that enzyme. Even though it's a potent inducer, it will not affect its efficacy. ESBL, and it's critically ill or outside the urinary tract. You always use a carbapenem. It's the drug of choice. For simple infections, you could use Bactrim or nitrofurantoin. For complicated UTI, you can use Bactrim. It reaches good concentrations in the kidneys, or fluoroquinolones. Because fluoroquinolones levofloxacin gets good tissue concentrations in the kidneys as opposed to ciprofloxacin, which concentrates better in the urine. But when toxicities prevent their use, then you could use a carbapenem. Zosyn or cefepime are non-inferior, but generally avoided when you can use a carbapenem. Now, cefepime gets tricky. So the data has always swung between carbapenems and Zosyn and cefepime for this, but when in doubt, always use a carbapenem when you are really thinking about ESBL infections. There are newer drugs which can be efficient and effective, but when a carbapenem is susceptible, you don't want to use these newer drugs. You want to preserve them for difficult to treat infections. Now, carbapenem-resistant Enterobacterales. For cystitis, you can use simpler options such as nitrofurantoin, Bactrim, fluoroquinolone. Colistin is mentioned, but I would rather not use colistin because of the toxicity profiles, because of the non-reliable PK/PD parameters. For complicated UTI, you could use the same if they are susceptible because they achieve good kidney concentrations. For non-UTIs infections, if they're not carbapenemase producing, not enzyme producing, then we could use an extended infusion meropenem or imipenem cilastatin with a higher dose, depending on the MIC values. If it's a KPC, which is a serine carbapenem, is the most common, it's often detected in the biofire, you could use any of the newer ones, the ceftazidime avibactam, meropenem vaborbactam, or imipenem relibactam. Cefiderocol, we'll talk about these drugs individually in the next few slides after we're done with the overview of these. For NDM, New Delhi strain, or the metallo-beta-lactamase, you could use a combination of ceftazidime avibactam with aztreonam, or cefiderocol has really come up as a promising drug for NDM infections. And similarly, for other type of carbapenemase, such as the OX48-like, here you could use ceftazidime avibactam or cefiderocol. Now, tigecycline or eravacycline for UTI or bloodstream infection, they don't have good blood concentration, so they quickly get distributed into the tissues. So really do not use them in serious infections. Now, difficult to treat Pseudomonas, MDR Pseudomonas, if it is susceptible to Zosyn and cefepime and susceptible to carbapenem, then you use Zosyn cefepime. If they are susceptible to Zosyn cefepime but resistant to a carbapenem, if they are not critically ill, you could use Zosyn cefepime. If they're critically ill, then you use some of the newer drugs. For difficult to treat Pseudomonas, it's the same. If it is simple, like cystitis, because it's a difficult to treat pathogen, it's a higher likelihood of bacteremia within an inadequate treatment. You go straight for the novel newer drugs. So no matter what the scenario is, the combination treatment for Pseudomonas is generally not suggested if susceptibility results are available and they are susceptible to the newer beta-lactamase inhibitor. The combination therapy has no role once the susceptibility results arrive, unless the MICs are so problematic that you had to use two drugs with higher concentrations to optimize your chances of recovery. crab, Acinetobacter baumannii, carbapenem resistant, it's very unclear because often you isolate in respiratory specimens and we don't know if it is true or contamination. It's often multi-drug resistant because it really has a lot of OXA carbapenemases. And a clear-cut regimen is really not active. But currently, there's a novel drug called sulbactam durlobactam in combination with a carbapenem, either meropenem or clindamycin. Meropenem or imipenem celastatin. Sorry, my bad, not clindamycin. Meropenem or imipenem celastatin. That combination has a better chance of success in serious infections. The alternative regimen, it used to be a preferred regimen, is a very high dose sulbactam. Sulbactam is not available a la carte in the US at least. It comes with ampicillin sulbactam. You target a dose that it gives an equivalent of 9 grams of sulbactam in combination with either minocycline or tigecycline or even cefiderocol. Cefiderocol, the data on crab is mixed, but it's still available as an option. Now, this is one slide that talks about all of these new agents. Before I go into this, we will talk about specific newer antibiotics because we're close to completion. Now, each drug, we will talk about the highlights. Ceftazidime tazobactam is Zerbaxa. This was FDA approved first in 2014. It is active for MDR and carbapenem-resistant Pseudomonas aeruginosa. If there's one thing that I want you to take out of this slide is the one highlighted. Of all the beta-lactamase inhibitor, this has the highest lung concentration. So obviously, if you're thinking about a difficult to treat hospital-acquired pneumonia, ventilator-associated pneumonia, you have ceftazidime tazobactam, Avicaz, which is ceftazidime avibactam, and meropenem avibactam. Of all the three, I would choose ceftazidime tazobactam. Make sure that the susceptibility results agree with it. There are tests that are FDA approved available for interpreting susceptibility results for these antibiotics. The trial results are as projected as you can see in the Aspect NP trial and the Cactus observational study where pneumonia patients is where the most benefit is seen. They do not have much activity against ceftazidime-resistant Enterobacter species or CRE because ceftazidime is like ceftazidime for the most part. Tazobactam is an older beta-lactamase inhibitor. Tazobactam doesn't really have a very comprehensive anaerobic cover, so you may have to add flagyl if you really want a robust anaerobic spectrum. Ceftazidime avibactam. Avibactam is FDA approved in 2015. Now, this is most widely studied beta-lactamase inhibitor of the newer ones in regards to intra-abdominal infections, complicated UTI infections. So if you look at the guidelines, it really puts it up on the top to be as a choice. It also doesn't have a good anaerobic cover. The problem with ceftazidime avibactam, the one thing to take out is because being more widely used than ceftazidime tazobactam that we are seeing a lot of emerging resistance. So it has a lower threshold than ceftazidime tazobactam. So you will see more evolving resistance. So treatment failures, there is a possibility if you use it widespread. So really conserving these are important. Meropenem avibactam, it preserves the activity of meropenem. It inhibits KPC and AMP-C only. And all of the three, as a matter of fact, ceftazidime tazobactam, ceftazidime avibactam, and meropenem avibactam, they do not have any effect on the metallo-beta-lactamases. They only inhibit the KPC. But meropenem by itself has excellent anaerobic cover, so you really don't need flagyl with it. On the right side, the image talks about what carbapenemases, what differences are there between avibactam and weberbactam, because both are newer beta-lactamase inhibitors. Imipenem relibactam. Now, imipenem relibactam, this also does not cover the metallo-beta-lactamases. It came into the market in 2019. It also inhibits KPC and AMP-C. Now, there are many other studies that are available in imipenem relibactam for difficult to treat MDR Pseudomonas. The lung concentration is about similar to Zerbaxa is what they report, but we don't really have a head-to-head comparison trials yet. But important to remember that it's a well-known, established and observed MIC creep that occurs when you use imipenem-relebactam. But it also is a promising option for Mycobacterium abscessus. If you treat MAC infections, Mycobacterium abscessus is painful enough to treat with all the options with its resistance profile. Imipenem-relebactam is coming up as a promising option for that. Sulbactam, durlobactam, as we spoke, it is promising for carbapenem-resistant Acinetobacter baumannii, and it's FDA approved in May 2023 for HAP and VAP, which is where predominantly crab is isolated. It's only IV formulation. It is renally eliminated, so renal dose adjustment is needed. The adverse effects are related to mostly hematological LFT enzymes and avoided in patients who have severe beta-lactam allergy. Now, there are more in the pipeline. There's cefepime N-metazobactam. There's Aztreonam avibactam. As you can see on the top, it's used for ESBL and Pseudomonas aeruginosa. Aztreonam avibactam preserves the activity of Aztreonam. These are approved in Europe, but not available in the US. And this year, in ID Week, they're talking about Nacubactam, which is the only standalone beta-lactamase inhibitor. They are planning to use it as standalone so that they want to really broaden its use with the already existing cefepime or Aztreonam. So that way, it allows for adaptation to the regional epidemiology based on what their antibiogram shows. And it's interesting to note that what they reported is it works by PB2 inhibition, beta-lactamase inhibition, and when put together, it enhances the beta-lactam activity, and they call it beta-lactam enhancement. And they are active against the metallo-beta-lactamases, the New Delhi metallo-beta-lactamase. So it's really coming up as a promising drug. They don't have any trial data to be published yet, but they presented some of the data from their Integral 1 trial. And Integral 2 trial is aimed to be completed in 2026. The Integral 1 trial results were promising, and they appear to be superior. So cefepime nacubactam and Aztreonam nacubactam sounds to be a very promising drug once it's available in the market. Hopefully, we should be able to use it. Then we have cefiderocol. Cefiderocol is really a novel, newer mechanism. It uses the ion transport mechanism of the bacteria. It cheats it, it gets inside, it dissociates, and then it goes and binds PBP3 and inhibits cell wall synthesis. And it's very interesting to look at this data because their trial data really showed inferior or worse outcomes for crab infections. But two of the trials, when they combined the data together and they looked at particularly the NDM or New Delhi metallo-beta-lactamase strains, that they had really a good chance of clinical cure and microbiological eradication, as well as mortality. You can see the mortality difference was huge, from 12.5% to 50%. And this included about 24 patients which had a combination of pneumonia, UTI, bacteremia. And they also pooled the results from all the case reports, which were published as post-marketing data, and showed that you could have a promising choice here when it comes to metallo-beta-lactamases. So if you're really dealing with an NDM strain, cefiderocol sounds to be a promising drug, but we need more clinical trial data, which is lacking. And plasmomycin is another drug which is mainly for, it's a aminoglycoside. It's approved for complicated UTI. It's a semi-synthetic aminoglycoside. So think about ototoxicity and nephrotoxicity. So to summarize, this is the rapid fire round for gram-negative drug resistance, which if you think about AMP-C, your choices are cefepime and carbapenem. If you are seeing or thinking about ESBL, then it's carbapenem. Then if you have a carbapenem-resistant Enterobacterales, without carbapenemases, you could use any of the newer beta-lactamase inhibitor. If it's your carbapenemase producing, then it depends on which one. If it's KPC, it can be ceftaz avicaz, which is ceftaz avi, meropenem vaporbactam, imipenem relebactam. If it is OX48, then it is ceftazidime avibactam or cefiderocol. And if it is a metallo-beta-lactamases, then you use a combination of ceftazidime avibactam and Aztreonam or cefiderocol as monotherapy. For non-serious infections, you could use the older drugs, fluoroquinolone, Bactrim, nitrofurantoin, depending on the context, or even aminoglycoside and fosfomycin if it is just in the bladder. Now, difficult to treat Pseudomonas infections. If it is lung infection, you use Zerbaxa, which has the best lung concentration, and the alternative is ceftazidime tazobactam with aztreonam. For Acinetobacter baumannii, you use at least two agents, one including ampicillin sulbactam at the current time because sulbactam durlobactam may not be widely available. And there's one bacteria which I didn't really talk about much for want of time, which is Stenotrophomonas, which we briefly spoke about, that it has an intrinsic carbapenemase. So in those, the drug of choice for Stenotrophomonas is Bactrim or minocycline or levofloxacin. And if it's a serious infection, use a combination. Levofloxacin has fallen more and more out of favor in clinical practice because of emerging resistance. All right. Now, in this slide, I want to give you a quick overview of certain common conundrums. Now, in any particular case of staphylococcal bacteremia, you can sometimes see MSSA and MRSA in the same patient. In which case, I would suggest using daptomycin because daptomycin is non-inferior to cefazolin. It is better than vancomycin for MSSA. Vancomycin is inferior therapy for MSSA. So in these situations, also, if it's a high inoculum infection, you could consider combo treatment to start with, and then determine in aggregate what is the most common isolate, what MICs make sense. Talk to your microbiologist, understand the lab assay differences, and then decide on what you are going to de-escalate to after demonstrating microbiological cure. There are situations where I've come across where the MIC for oxacillin was less than or equal to 0.5, but the biofire was positive for MEC-A. Now, this situation can be due to what's called oxacillin-sensitive MRSA or stealth MRSA. How do you treat? You treat that as an MRSA. There is a second test, more sensitive test than the MIC in the lab called cefoxitin screen. And it's a lab test that when it is positive, it's a more sensitive marker because cefoxitin is a more potent inducer of MEC-A. Now understand that MEC-A also is a gene for a beta-lactamase that's inducible. Now, there is more and more reports in the literature about oxacillin susceptible, cefoxitin screens negative, but MEC-A positive cases, which ultimately, when you expose them to serial concentrations in the lab, they turn out to be MRSA or they evolve into MRSA. So MEC-A positivity is quite important. If the genetic test is positive, the phenotypic result, if it is in discordance, you still go with the positive genetic test and assume and treat. The same applies for carbapenemases. If the carbapenemase genes are positive, but the susceptibility results say susceptible to carbapenem, there, do not use a carbapenem. Use a novel beta-lactamase inhibitor, depending on your clinical scenario. I want to end this presentation with a wonderful webpage from WHO, which prioritizes pathogens for groups in regards to what can be problematic, where is research needed, where should funding go, and etc. And they really have a very comprehensive webpage where all the drugs in development in different phases and what trials are there, what is upcoming, etc. I refer you all to that for a more comprehensive review. As you can see, that I didn't cover a lot of problematic bacteria like Neisseria gonorrhoeae or Salmonella typhi or Mycobacterium. We only spoke about the common bacterial infections that we come across in clinical practice. I would do want to, I don't know how we are doing in regards to timing here. We probably went a little more overboard than what I'm supposed to do.
No problem. You can play this video.
Okay, I don't know how many of you have seen this video, but it really opens up our understanding of antimicrobial resistance. I don't know how to bear with me on this little ad that is up.
New Infinity QX80 and QX60 Sport are dark chrome.
Sir, you need to share the new
Correct.
screen.
Yes. I am stop share. Share. There.
So are you not able to play the video, Hari?
I think,
So we ended up building was basically a petri dish.
Is it audible?
Yeah.
Okay.
Continue to play. I think it is
Yes.
stopped.
Except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic up until the point they can no longer survive. Then a mutant appears on the
video
right.
is not moving, I think.
It's resistant to the antibiotic. It's spread.
Hariharan sir, hello.
Yes. Is it not?
Sir, the video is not playing. I have left the link in the chat box for those who want to see.
Yeah, no, that makes sense. Yeah, I was afraid that it may not play well, but
Yeah.
Watch it. It's a very eye-opening thing on how it makes us think about overuse of antibiotics and curb its use. I'm happy to take questions. Sorry for going a little overboard.
No problem. So there are 2 questions. So there's a question by Dr. Sudarshan. With limited regulations on disposing leftover antibiotics, what measures should healthcare institutions adopt to ensure responsible disposal and protect the One Health approach?
Good question. Definitely not down the drain or the toilet drain, because there's a lot of assays and analysis on looking at the drain fluid, or in other words, the sewage fluid, to foster antimicrobial resistance gets out in the wild and doing it. The best thing is to dispose it off as a biohazard with giving it back to your, because the pharmacy. They know how to dispose of unused medications, and it is the same way that you go and give it back to them is how we generally say, be it narcotics, be it antibiotics, be it any unused antibiotic, you go and dispose them off. The right way is to give it back to where they can dispose it off as a biosafety hazard. So that's really the best way to do it. I don't know if it is feasible in India where you can just walk into a pharmacy and get whatever you want and people just throw it out. So I really don't know how to approach it there, but I assume it's going to be similar.
Yeah. Or else return to the hospital,
Yeah, exactly. Yes.
Good, bigger tertiary care centers or where there's a good disposal. And there's another question from Venkat Ramesh. What if no genotypic testing is done in MSSA infections? Yeah, the role of genotypic testings, then you really have to wait for susceptibility results. I assume that is the question, because genotypic testing is a tool to quickly recognize the appropriate therapy. If it is gram-positive cocci in clusters that's growing in your blood cultures, if you do the biofire that comes out in a couple of hours that tells you if it's MSSA or MRSA, then you can really pin down and start your targeted therapy faster. But if you really don't have, that's the real utility of having that biofire or the MECA results available. If you do not have that, it's safer to start with a vancomycin and a beta-lactam combination, and then you de-escalate. Now that depends on how sick your patients are too. If they're more sicker, I would always encourage to have vancomycin and a beta-lactamase, or depending on your syndrome that you are treating. Do we have any other questions? Akshata, can you just check?
I see a question that says how to assess high inoculum infection. I believe that is based on your clinical evaluation bedside. Deep-seated infections such as osteomyelitis or endocarditis are sometimes like infected clots with a high, in other words, the time to positivity in blood cultures. Let's say you collected blood culture at 10 o'clock and it turns positive within a few hours. That is a high-grade bacteremia. You have a complicated intra-abdominal infection or an infected graft, a vascular graft, or a spinal epidural abscess with a lot of vertebrae involved. Sometimes we see osteomyelitis, hip joint infections with a lot of effusion, bone necrosis. So that sort of the burden of the infective burden needs to be high, and the degree of illness also needs to be severe. There definitely we think about high inoculum infections, and then what matters is how are we going to achieve the source control? Just antibiotics alone are not going to cut it. You need to have a surgical approach. You need to drain it. You need to remove the devices, etc. Until you bring down the inoculum to lower levels, which will reflect in your microbiologic cure and clinical response based on how you treat. So this is really how I assume it high inoculum to start with in these sort of scenarios. Then you approach it with an effective approach. It seems like the evidence is pointing more and more towards trying to use a combination therapy in the beginning and then scale down to an appropriate monotherapy based on the MIC values for either vancomycin or cefazolin, depending on what you're treating. Hope that answers that question.
Thank you, Hari. Your presentation was excellent, and you've answered all the questions. And it was very important to stress source control, as you just mentioned, in addition to antibiotics, which is very important principle in treating infectious diseases. And thank you very much. Akshata, would you like to conclude?
Yes, that brings us to the end of the first day. So I request all of you to join the rest of the days. Each day it is at 6:30 to 8, and we have one national and one international speaker who is going to address the common syndromes along with another interesting topic. So I request all of you to join tomorrow at the same time. Yes, thank you.
Thank you very much, all the audience. Thank you. And to the speakers, Dr. Hari and Dr. Sagarika.
Thank you, madam. It was
Bye.
a pleasure. Bye.
Thank you, ma'am.
And for those who are asking about the recording, we shall be, after all the completion of all the sessions, we shall put the recording in the link shared before. Thank you.
Thank
Good
you.
night.
Good night.